Today, we'll be looking at fluid and electrolyte imbalances. This is a condition where the levels of fluid and electrolytes in the body can become either too high or too low. We're going to be covering ADH disorders, adrenal disorders, calcium imbalances, fluid volume deficits and overload, magnesium imbalances, potassium imbalances, and also sodium imbalances. So just to recap, we have our pituitary gland here. Remember, this is the small pea-sized gland that plays a major role in regulating vital body functions and general well-being. It's actually referred to as the body's master gland because it controls the activity of most other hormone-secreting glands. It has two distinct parts. There's the anterior pituitary and the posterior pituitary gland. And each, it actually has hormones it secretes that target special or different organs. For example, we have our ACTH hormone, which is your adrenocorticotrophic hormone, and this target organ is the adrenal gland. We also have the follicle stimulating hormone, for example, and the luteinizing hormone. They both target the ovaries and the testes. There's also the prolactin that targets the breast. There's also the thyroid stimulating hormone, which targets the thyroid gland. There's also the oxytocin that also targets the breast. We have the growth hormone that targets the bone and tissues. And then there's the ADH, the antidiuretic hormone, or vasopressin, which targets the kidneys. That's just to remind us of our basic anatomy. We'll be starting with diabetes insipidus. Diabetes insipidus is an ADH disorder, an antidiuretic hormone disorder. It causes an imbalance of fluids in the body. And this leads to the body producing large amounts of urine. It makes one very thirsty, even if the person had something to drink. So you can just see this is a normal, what it should be. The pituitary gland sends the ADH hormones to the kidneys, and this helps control how urine is made. So we have a normal volume of urine, but here the kidneys are not responding to the antidiuretic hormones, and as a result, they make a whole lot of urine. So what you're going to see in this client is going to be excessive urine output. There's going to be chronic severe dehydration as it's losing so much fluid or is making so much fluid. It's going to be excessively thirsty. There will be weight loss. There will be weakness and constipation. As more fluid is withdrawn from the feces, it's going to be really constipated. Diabetes insipidus could be as a result of head trauma, brain tumors, encephalitis, the meningitis, or a deficiency of the antidiuretic hormone. We can carry out some specific tests to diagnose this condition. For example, you will see low specific urine gravity or low urine specific gravity if we carry out urinalysis. Ideally, the urine specific gravity results should fall between 1.002 and 1.030. So if your kidneys are actually functioning normally, it should be between 1.002 and 1.030. Specific gravity results above 1.010 can indicate mild dehydration. So the higher the number, the more dehydrated the client may be. So use this to remember high and dry, high and dry. So the higher the number, dehydration, dry. It's getting dry as it's losing more fluid, so high and dry. Again, we can also look at urine osmolality. So what you will see in this client is urine osmolality that is below plasma level. Remember, your urine osmolality is a measure of urine concentration in which large values indicates a concentrated urine and small values indicate a diluted urine. So an individual with a normal diet and normal fluid intake usually should have a urine osmolality of approximately between 500 to 850 milliosmol per kg of water. So what's our nursing consideration for a client with diabetes insipidus? We want to keep strict intake and output record. You want to monitor urine-specific gravity. Remember, we said high and dry. The higher the urine-specific gravity, it means it's more dehydrated. Again, you want to monitor skin condition. That could tell you how hydrated your patient is. We also want to keep a strict weight record. If he's retaining fluid, we want to know about that. Or if he's not, if he's losing weight, you want to monitor that. We also want to monitor other vital signs like the blood pressure, his pulse, and temperature. And we may need to administer our vasopressin or the antidiuretic hormone to treat this condition. Another ADH disorder would be syndrome of inappropriate antidiuretic hormone secretion. This is the opposite of what we had in the last slide. This is actually an issue of increased ADH secretion. So there's inappropriate ADH secretion. So in this condition, the body makes too much antidiuretic hormone. This hormone helps keep the kidney or helps the kidney control the amount of water the body loses through the urine. So SIADH would actually cause the body to retain too much water. So you can see some of the causes here. It could be as a result of primary brain injury from meningitis or from a subarachnoid hemorrhage. It could also be as a result of infection like pneumonia or cerebral abscess. It could also be caused by drugs like your carbamazepine or your SSRIs or the amitriptyline or morphine. Again, it could also be caused by small cell lung cancer. So all of this can cause SIADH. Also included will be your positive pressure ventilation. And again, if you have a feedback mechanism that is deficient, normally you have a feedback mechanism that regulates ADH. If it's not functioning properly, ADH would be released into the bloodstream, even when the plasma hypoosmolality is present. So that could also cause SIADH. Some diagnostic tests we can run for this client would be to some blood tests where we'll find out that the serum sodium is decreased because of the effects of the antidiuretic hormone. Again, plasma osmolality is also decreased. And again, you will see increased urine-specific gravity. In terms of assessment of this client, what would you see? There will be anorexia, there will be nausea and vomiting. The client would also be lethargic. There will be changes in level of consciousness. There will be decreased tip tendon reflexes. His heart rate is going to be fast. There will be an increased circulatory blood volume as a result of the effects of the ADH, the excess ADH secretion. And again, there will be the obvious decreased urinary output. So we want to restrict water intake in this client to at least between 500 to 600 ml within 24 hours. Again, we might need to administer diuretics to help promote excretion of the water that he's retaining. You can also give hypertonic saline, like an IV. We can give like 3% sodium chloride. Again, we might need to administer dimeclocycline. This is used to treat infections caused by bacteria, including pneumonia and other respiratory tract infection. Remember, we said this could be as a result of infection. So we might need to administer this medication to treat any infection. Again, we will still need to weigh the client daily to monitor his weight gain or weight loss. We'll need to keep strict intake and output charts. We also want to monitor his serum sodium levels and keep assessing his level of consciousness. Let's look at Addisons disease. This is also called adrenal insufficiency. Remember, the adrenal glands are located just above the kidneys. And in this condition, they produce too little cortisol and often also too little aldosterone. So that's your adrenal gland, just located above the kidneys. Remember, the adrenal gland has two parts. There's a cortex, which is the outer part, and there's a medulla, which is the inner part of the gland. And the cortex, which is the outer part, produces the hormones cortisol and aldosterone. So what we have in this case is there's hyposecretion of the adrenal hormones. The adrenal hormones are our mineralocorticoids, glucocorticoids, and androgens. You will see that these are produced from the cortex of the adrenal gland. So remember, your mineralocorticoids influence salt and water balances. They include the aldosterone and the corticosterone. So these are our mineralocorticoids. They influence salt and water balance. They also promote sodium and potassium transport. This also has a role it plays in water balance. So most times in this client, you're going to see decreased sodium levels. There will be dehydration. There will be decreased blood volume and shock. There will also be increased potassium levels. There will be metabolic acidosis and arrhythmias. You would also see decreased blood sugar levels, and the client would also experience insulin shock. If we look at our glucocorticoids, these are a type of corticosteroid hormones that are very effective at reducing inflammation and suppressing the immune system. Remember, inflammation is the way our immune system responds to harmful substances and trauma, and it's part of the healing process. So we also have the cortisol and cortisone that are part of they make up our glucocorticoids. And finally, we have the androgens, which also regulate the development and maintenance of male characteristics. So what diagnostic tests can we run for our client who has Addisons disease? We can do CT and MRI. Remember, we said potassium levels will increase, so our blood tests will show hyperkalemia. We also said the sodium levels will be decreased in Addisons disease, so we would also see hyponatremia. Also, our plasma cortisol, because we are not having the cortex produce these hormones, so you're going to see decreased plasma cortisol. We'll also see decreased urinary 17-hydroxycorticosteroids and 17-ketosteroids. So these would also be decreased in the urine. Okay, we can also run ACTH stimulation tests. So what's this test about? It measures the ability of the adrenal cortex to respond to ACTH by producing cortisol, which is what it's supposed to do. So in the presence of ACTH, the adrenal cortex should be stimulated to produce cortisol. So what happens here is that you collect an initial blood sample, and then a small amount of a synthetic fragment of ACTH is injected into the client, either through IM or IV. Then additional blood samples are taken 30 minutes or 60 minutes after the IV injection. So a normal increase in the cortisol level is expected. So post-stimulation, blood cortisol should be greater than 20 micrograms per DL. So normal results are for adults between 6 to 76 picograms per milliliter. So you want to see an increase in the cortisol levels. So remember some of the signs you will see in your client with Addison's disease. There will be hyperpigmentation of the skin. We'll see low blood pressure. There will be weakness and weight loss. Remember, the adrenal glands are not producing sufficient steroid hormones. We'll also see nausea, diarrhea, vomiting, constipation, and abdominal pain. And in the skin, we can see vitiligo. So these are some of the signs or symptoms you can see in your client with Addison's disease. So what's our plan for this client? We want to maintain him on high protein. Remember we said he's going to be weak. So we want to give him high protein, high carbohydrate for the energy. We also want to give him high sodium. Remember we talked about hyponatremia. And we also want to give him low potassium because we already talked about seeing hyperkalemia in this client. So high protein, high carbohydrates, high sodium, low potassium diet. We also want him to wear a medical art bracelet because clients with Addison's disease can go into an Addisonian crisis. So we want to know what's happening with this client. We want him to wear a bracelet that gives us this information. Again, because it is not producing enough glucocortisols, we want to protect this client from infection. Remember, the plasma cortisol levels is decreased, so you want to protect him from infection. We also want to monitor for hypoglycemia. Remember we said the blood sugar levels is decreased in Addison's disease. You also want to monitor for hyponatremia, the low sodium levels we talked about. Again, we'll need to assist with 24-hour urine collection for our 17-hydroxycorticosteroids. During this process, so this is a container that we can use to collect the urine samples, the 24-hour urine collection. You want to refrigerate the urine during the collection period. So remember, a 24-hour urine collection is done by collecting your urine in a special container over a full 24-hour period. And this container must be kept cool until the urine is returned to the lab. Again, we'll need to administer hormonal replacement for this client. And you need to remember that this may be a lifelong hormonal treatment. So you might need to continue it for life. Again, remember we said this client could go into Addisonian crisis. So we need to avoid factors that can precipitate this client or causing this client to go into Addisonian crisis. Remember, Addisonian crisis is a serious medical condition that is caused by the body's inability to produce a sufficient amount of cortisol. Addisonian crisis is also known as acute adrenal crisis. So what are the precipitating factors? Physical stress, psychological stress, and again, inadequate steroid replacement. So these could cause the client could go into Addisonian crisis. Physical stress, psychological stress, and inadequate steroid replacements. So we need to observe for clinical manifestations of Addisonian crisis in this client. Remember, we said it could be precipitated by physical, emotional, psychosocial stress, or even sudden withdrawal of these hormones from the client. So what are the clinical manifestations? There will be nausea and vomiting. The client will complain of abdominal pain. There will be fever, extreme weakness. So there's extreme weakness. Again, there's severe hypoglycemia. So blood levels are severely low. Potassium levels shoot up the roof. So there's hyperkalemia. Remember, you want to be conscious of hyperkalemia because of the role potassium plays in the cardiac electrophysiology. And again, dehydration, severe dehydration develop rapidly. So you're looking out for these signs: severe hypoglycemia, severe hyperkalemia, and severe dehydration. And remember, they could develop rapidly. Again, the blood pressure falls in this client in Addisonian crisis. There's a marked blood pressure drop that leads to shock and coma. And remember, death can result if this is not treated promptly. So how do you want to treat the client in Addisonian crisis? We want to administer hydrocortisone therapy. We want to monitor IV infusion. We can give 0.9% sodium chloride or D5W sodium chloride. We'd also need to administer IV glucose or even glucagon. Remember, we said there's severe hypoglycemia. And also want to administer insulin with dextrose in normal saline. Because of this hyperkalemia, we will need to administer kayakzylate to help us to bind to this potassium, excess potassium, and help in excreting it. So we can administer our potassium binding and excreting resin, for example, your sodium polystyrene sulfonate, also known as kayakzylate. Again, we still need to monitor the client's vital signs. Now let's look at Cushing's syndrome. So we have a picture here, and you can see this client has Cushing's syndrome. Cushing's syndrome is a condition that occurs from exposure to high cortisol levels for a long time. Remember, in Addison's, we didn't have enough cortisol, but in Cushing's, we now have excess of this cortisol for a long time. So there's hypersecretion of our adrenal hormones like your mineralocorticoids, the glucocorticoids, and the androgens. So usually the most common cause is the use of steroid drugs, but it can also occur from overproduction of cortisol by the adrenal glands. So what would you see in your clients? This time around, it's going to be the opposite. We're going to see increased potassium. We're going to see increased blood volume. We're going to see increased blood pressure. This time around, the potassium is going to be reduced or drops. There will be metabolic alkalosis and shock. There would also be increased blood sugar, which can also lead to ketoacidosis. So this is the opposite of most of what we saw in Addison's disease. We can run diagnostic tests like the skull films. We can do a skull X-ray to see what's happening with the glands. We can also carry out blood sugar analysis. Remember, we talked about the blood sugar being elevated. We're also looking out for hypokalemia from the decreased potassium levels, and also hyponatremia from the increased sodium levels. This time around, the cortisol levels are going to be increased. In addition to our urinary 17 hydrocorticosteroids and 17 ketosteroids, these would also be increased. So now we see our the hypothalamus stimulates the pituitary gland, which secretes the ACTH, that stimulates the adrenal gland, but instead it's producing too much adrenaline or your cortisol. Remember, the adrenal glands are located just above your kidneys. So some of the signs you will see in these clients, will see red cheeks. Again, they will have this kind of moon face. You see this moon face. So that tells you this client possibly has Cushing's. Again, there's osteoporosis. The bones are brittle. There's going to be bruises and ecchymosis. The client is easily bruised. Again, there will be high blood pressure. You would also have this pendulous abdomen with this red or purple striae on the abdomen. The skin is very thin, and you also see thin arms and legs compared to the body frame. There will also be poor wound healing. So you're looking out for the moon face. There's also these fat parts or your buffalo hump. This is what we call a buffalo hump. So this is a giveaway that tells you the client has Cushing's syndrome. And then there's a pendulous abdomen with all of these purple or reddish striae. So you see these thin limbs. So these are as a result of muscle weakness or muscle wasting. Again, the client will also complain of fatigue. There could be edema. The client could be depressed. There's also the blood sugar imbalance, which we already talked about. So you want to assure this client in terms of our nursing consideration. We want to assure the client that most physical changes he's experiencing, the moon phase, the buffalo hump, and all of that, they are reversible with treatment. We also want to give this client a high protein, low carbohydrates, high potassium. Remember, we said the potassium level is decreased. So we want to give high potassium. We also want to give low sodium. Remember, the sodium level is increased. So you want to give low sodium and low calorie diet. We also need to restrict fluid in this client. We also need to be careful, want to use techniques that could prevent infection. Again, eliminate hazards that could lead to pathological fractures. Remember, there's osteoporosis in this client. You also want to observe for hyperactivity, GI bleeding, fluid volume overload. So you want to observe for all of this. And then we'll need to administer aminoglutamide or metirapone. This would help to decrease the cortisol production. So treatment option also for this client would include or can include surgery, where we can carry out adrenalectomy, which would be a surgery to remove one or both adrenal glands. So you can see the adrenal gland is being taken off. So we'll need to provide post-adrenalectomy care. So remember, the kidneys are on the side, so there's going to be some flank incision to access the kidney. So we need to be cognizant of that, because that incision is going to be make it painful for the client to breathe. So you need to encourage coughing and deep breathing in your client. Also, you want to ensure client safety to decrease risk of fractures, like we already discussed. You also want to monitor for shock in this client, monitor for hypertension. And again, we'll need to administer the cortisone and mineralocorticoids as ordered. You also need to anticipate slow recovery from anesthesia in obese clients. Remember, we saw our clients, it could be obese due to the weight gain. So you want to monitor, you want to anticipate slow recovery from anesthesia. Again, you also want to anticipate slow wound healing. Remember, we said our clients already had those conditions, even being easily bruised and all of that. So you want to anticipate slow wound healing. You also want to monitor glucose level and monitor urine outputs. Let's look at other imbalances related to, for example, calcium. Remember, calcium is needed for blood clotting, skeletal muscle contractions, and all of that. And our normal blood calcium level should be between 8.6 milligram per DL to 10.2 milligram per DL. Our calcium is regulated by the parathyroid hormones and vitamin D. Remember, vitamin D facilitates reabsorption of calcium from the bones and enhances absorption from the GIT tract. So these are parathyroid gland. So it secretes the parathyroid hormones, which regulates calcium levels in the blood, largely by increasing the levels when they are too low. And how does it do this? It does this by its actions on the kidneys. So it has the parathyroid hormone would act on the kidneys and reduce calcium clearance, and also help to activate vitamin D. It also does this on the bones. So the PTH acts on the bones and cause them to release calcium from large calcium stores in the bone will be released into the bloodstream. It also has its effects on the intestines or the GIT tract, where activated vitamin D would help absorb calcium in the gut. So we can have low or high levels of calciums. So if it's low, we'll refer to that as hypocalcemia. And hypocalcemia, low calcium level, can be caused by hypoparathyroidism, pancreatitis, renal failure, steroids, and loop diuretic use, inadequate intake, and also post-thyroid surgery. So in terms of assessment, we'll see levels below 8.6 milligram per DL. We'll also notice that the nervous system becomes increasingly excitable. Again, there will be tetany. What's tetany again? Is a condition that is due to low blood calcium levels, and is characterized by spasms of the hands and feet. You also notice cramps, spasms of the voice box or your larynx, and overactive neurological reflexes. So we can see the Trousseau sign in this client. So this would be your Trousseau sign. And how do you elicit this? You want to inflate the BP cuff on an upper arm to 20 millimeters of mercury above the systolic pressure. And you would witness or notice carpal spasms within 2 to 5 minutes. So if you notice carpal spasms within 2 to 5 minutes after you've inflated the cuff to above or to at least 20 millimeters above the declined systolic pressure, then that's positive of tetany. Again, you could also elicit the Schoenfeld sign, which would be when you try to tap the facial nerve. This is at least 2 cm anterior to the earlobe, just below the zygomatic arch. What would you notice? There will be twitching of facial muscles. This also indicates tetany. Other assessments we'll see in these clients would include seizures. There will be confusion. There will be paresthesia, which is an abnormal sensation, that tingling or prickling or pins and needle sensation that's caused chiefly by pressure or damage to the peripheral nerve. So this could be seen in this client. And again, the client become easily irritable. So we can replace the low calcium by giving calcium gluconate orally, or we can give calcium chloride. Again, you want to administer with orange juice to maximize absorption. So you want to note that down. You want to give calcium gluconate with orange juice to maximize absorption. Parenterally, we can give calcium also gluconate parenterally. Again, we need to know that the effect is transitory and additional doses may be required. You also want to use caution with digitalized clients because both calcium and digitalis are cardiac depressants. Calcium may cause vessel irritation, so they should be administered through a long, stable intravenous line. So again, remember, orally want to give with orange juice to maximize absorption. And if we're giving IV, because it can irritate the vessels, you want to give through a long, stable intravenous line. Again, avoid infiltration, since tissue can become necrotic and slough off. You want to administer at a slow rate to avoid high serum concentrations and cardiac depression. Watch out for seizures. Maintain airway because laryngeal stridor can occur with calcium use. Again, you also want to maintain safety, especially the safety needs of this client, since confusion is often present. You also want to increase dietary intake of calcium. And even if we can give calcium supplements. We also need to engage the client in regular exercise. And we can also administer phosphate-binding antacids. We can also give calcitrol. We can also give vitamin D. In terms of hyperkalemia, or hypercalcemia, sorry, this is a condition in which the calcium level in the blood is above normal. So we'll see levels above 10.2 milligram per DL. So you have too much calcium in the blood, which would weaken the bones. It would help to create kidney stones. It will interfere with how the heart and the brain works. It's usually a result of an overactive parathyroid gland. So in terms of assessment, what do we see in our clients? We're going to see confusion in this client. There's going to be muscle weakness, there's going to be bone pain, like we said, kidney stones, and then dysrhythmias, even cardiac arrest. Again, there will be excessive urination in this client. Also, would also see decreased or absent tendon reflexes in a client with hypercalcemia. And remember, there's this sedative effect on the central and peripheral nervous system. So like we already said, it's usually caused by malignant neoplastic diseases. It's also caused by hyperparathyroidism, which is when the parathyroid glands create too much parathyroid hormone in the bloodstream. Again, excessive intake of calcium could cause this. Being immobile, like patients who have been admitted for long and are immobile or are bedridden, they could also come down with hypercalcemia. Excessive intake of calcium carbonate antacids could also cause this condition. In terms of our plan and our management of these clients, we want to give IV administration of 0.45% sodium chloride or 0.9% sodium chloride. We want to encourage fluid in these clients. We might need to give furosemide. We might need to give calcitonin. This would help to decrease calcium level. We need to mobilize the clients, get him up and about. We also want to restrict dietary calcium. We don't need the extra calcium or the excess calcium. Again, we need to take measures to prevent development of renal calculi. We want to maintain an acidic urine, which would help to prevent infections. We also want to prevent UTIs, urinary tract infections. Again, surgical intervention may be indicated in these clients, especially if there's hyperparathyroidism. And also you want to limit intake of calcium carbonate antacids. Let's look at fluid volume imbalances. With fluid volume deficits, for example, or hypovolemia, here the fluid output exceeds the fluid intake. And it occurs when the body loses both water and electrolyte from the extracellular fluid in similar proportions. So what are you going to see in your clients? There's going to be thirst, which is an early sign of a fluid volume deficit. There could be temperature increases. The pulse become rapid and weak. Respirations also increase. There's also poor skin turgor. So the skin is cool and moist. Because of the deficit, there's hypotension, there's weight loss. You will notice dry eye sockets, the mouth, the mucous membrane, they're all dry. The client could be apprehensive. Our urine specific gravity will be greater than 1.030. Remember, we said high and dry. So he's losing fluid, meaning his specific gravity will be high. Again, there will be decreased urine output because he doesn't even have enough fluid in his circulatory volume. The hemoglobin will be increased. The hematocrit will be increased. The serum osmolality would also be increased. The client could also have headache, lethargy, confusion, disorientation, and all of that. So how do we manage these clients? We want to force fluids, and we also want to measure all fluids that enter and leave the body. We can provide isotonic IV fluids like your lactated ringers or sodium chloride 0.9%. We also need to keep a strict intake and output chart, like we already said, and want to keep hourly outputs. We also want to check electrolyte CBC and urine specific gravity. So those are the laboratory values we need to follow up on these clients. We also need to assess for hypotension. Remember, we said he would suffer from hypotension, and also want to evaluate for weak pulses. In terms of respiratory, we want to assess respiratory system. Remember, we said respiration would increase because that will give us an idea of tissue perfusion, oxygenation and ventilation and all of that. So you also want to check orientation, vision, hearing, reflexes, and muscle strength. We also want to check for weight changes. We also want to check for skin breakdown and good oral care. In terms of volume overload, so this refers to expansion of the extracellular fluid volume. And this typically occurs in heart failure, kidney failure, nephrotic syndrome, and cirrhosis of the liver. It's also seen with excessive or too rapid intravenous infusion, and also with excessive ingestion of sodium. So what do we see in our clients? So we're going to see, let's look at the neurological changes first. There will be changes in levels of consciousness. There will be confusion, headache, and seizures. With respiratory system, we're going to see the respiratory rate is going to increase, or respirations increased. And we'll see signs of pulmonary congestions. What are signs of pulmonary congestions you might see? There will be shortness of breath. There will be dyspnea. You will hear rails and crackles when you listen to the chest. In terms of the GIT, there will be anorexia, there will be nausea, there will also be weight gain. The client will actually have this bloated appearance because there will be edema, pitting, dependent pitting edema will be obvious in the client. In the cardiovascular system, we're going to see bounding pulses. The blood pressure is going to be elevated. There's going to be elevated jugular venous distension. There will also be presence of S3 sounds in the heart, and also there will be tachycardia. So what's our plan for this client? Because of the excess fluid volume, we want to administer diuretics. We also want to restrict fluids because he's already retaining, he has excess volume already. We want to restrict fluids. We also want to give a sodium-restricted diet to this client. We also need to follow up and monitor his breath sounds because we said there will be signs of pulmonary congestion. Also want to check the feet, ankle, and sacral region for edema. You can see where we have the edema, the dependent pitting edema. And again, if this client becomes dyspneic, having difficulty breathing, we want to keep him in a semi-Fowler's position. Let's talk about magnesium imbalances. We could have, normally our magnesium level should be between 1.3 to 2.3 milliequivalents per liter. So if it's less than that, we can say the client has hypomagnesemia. So we have low levels of serum magnesium. And this hypomagnesemia can be attributed to abuse of diuretics or laxatives. It could also be attributed to chronic diseases. Again, it's also seen in clients with alcoholisms. You could also have magnesium loss through the gastrointestinal tract. For example, if the client has intestinal fistulas, he can be losing magnesium from frequent GI suction and even diarrhea. We would have losses of magnesium from this route. There could also be renal losses. And hypomagnesemia is also seen with other electrolyte deficits. So in terms of assessment, remember magnesium acts as a depressant. So we are going to see increased neuromuscular irritability. So there's going to be tremor, tetany, there's going to be seizures, there's going to be weakness, apathy, delirium, and even coma. In terms of cardiovascular manifestations, we could see prolonged QT intervals, prolonged QTCs, widening of your QRS complexes. Remember, we want our QRS complexes to be within 2 to 3 small boxes, but with hypomagnesemia, it's going to be widened above 5 small boxes. There could also be atrial and ventricular dysrhythmias. In terms of our plan for this client, we want to increase intake of dietary magnesium to replace the loss. So we need to give this client green vegetables, nuts, bananas, oranges, peanut butter, even chocolate to increase his magnesemia or magnesium level. We could also give parenteral administrations of supplements like your magnesium sulfate. We'll need to monitor cardiac rhythm. Remember, we said we have some cardiovascular manifestations, so you need to monitor his cardiac rhythm and also his reflexes to detect the depressive effects of this low level of magnesium. Again, we want to keep, so this is very important, we want to keep a self-inflating breathing bag and also oxygen at the patient's bedside in case of respiratory emergency. So we keep monitoring his respiratory status and his airway, and we're ready to intervene if there's a reason to, or if he has a respiratory emergency. Also, we can give calcium preparations. This could help to counteract the potential danger of myocardial dysfunction that may result from magnesium intoxication. secondary to rapid infusion. So let's assume we are giving magnesium sulfate. If we give too much, there's a potential danger of myocardial dysfunction. So you want to have your calcium preparations nearby, which you'll need to give to counteract the effect of hypermagnesemia. Again, we could give oral magnesium. So that will be on a long-term maintenance with oral magnesium, or can give IV. When you're giving IV administrations of magnesium, you want to assess renal function. Again, we want to monitor for digitalis toxicity. We want to maintain seizure precautions. Again, provide safety measures because confusion is also present in this client. And you need to test the client's ability to swallow before oral fluids or even food because of dysphagia. So again, like we said, we could have hypomagnesemia or hypermagnesemia. So in hypermagnesemia, you are seeing levels above 2.3 milliequivalent per liter. Remember, we said the normal is 1.3 to 2.3 milliequivalent per liter. So there's a high level of magnesium in the blood. And some symptoms you would see would be weakness, there will be confusion, there will be decreased breathing rates, there will be decreased reflexes also. So it's usually caused by excessive intake of magnesium-containing antacids or cathartics. It could also be caused by renal failure. So in terms of assessment, we know that magnesium depresses the CNS. It could also depress cardiac impulse transmission. So you would see bradycardia in this client. You will see hypotension. There will be facial flushing. It would also cause muscle weakness. There would also be absent deep tendon reflexes. There could be paralysis. And again, that's shallow respirations we talked about. So part of your plan would be to discontinue oral and IV magnesium if you're giving and the client goes into hypermagnesemia. You want to stop it immediately. It's an emergency. Because you say it can cause shallow respirations, we want to see this as an emergency and support ventilation. We will need to give calcium gluconate to counteract the effects. We might need to carry out hemodialysis. We will need to monitor the client's reflexes. And you also want to teach your client about over-the-counter drugs that contain magnesium. Also, you need to monitor the cardiac rhythms. Remember, we said hypermagnesemia could depress cardiac impulse transmission and cause bradycardia and hypotension. So you want to monitor cardiac rhythms and also have calcium preparations available to antagonize this cardiac depression. In terms of potassium imbalances, remember potassium is one of the main intracellular ions. It's involved in cardiac rhythm. It's also involved in nerve transmission. The normal levels for our potassium should be between 3.5 to 5.5 milliequivalent per liter. What are the causes of hypokalemia? So you're going to see a client could be hypokalemic as a result of vomiting or gastric suctioning or diarrhea, or if he uses, if he's on diuretics and steroids, or if he's even having inadequate intake of potassium. So those are some of the causes of this condition. So what would you see in your clients? There will be shallow respirations, there will be irritability, there will be confusion and drowsiness. The client would exhibit weakness and fatigue. There would also be arrhythmias. You would see tachycardias, irregular rhythm, and or bradycardias. So remember, we're looking at hypokalemia. Again, the client will be lethargic, his pulse will be steady, and there will be decreased intestinal motility. And that's why you see your nausea, vomiting. You could also have paralytic ileus. But how about hyperkalemia? What could cause the levels to go up above 5.5 milliequivalent per liter? It could be as a result of renal failure or use of potassium supplements. Again, we could also see hyperkalemia in bones or crushing injuries. So what do we see in this client? You're going to see muscle twitching that can lead to weakness and subsequently lead to flaccid paralysis. The blood pressure will drop. We're going to see ECG changes. So you're going to see tall peaked T waves. So you're going to see tall peaked T wave. So that's one giveaway of your hyperkalemic client. So this is your P wave, your QRS complex, and this is your T wave. So you're going to see peaked T waves, tall peaked T wave. That tells you the client has hyperkalemia. Again, we're going to see dysrhythmias. There will be irregular rhythms, and there will also be slow rhythms. There could be abdominal cramping. There could also be diarrhea. So with hypokalemia, you want to administer oral potassium supplements. Again, dilute in juice to avoid gastric irritation. So you want to dilute your potassium supplements in juice to avoid gastric irritation. You also want to increase dietary intake of potassium. So these are some foods that are high in potassium. There is the avocado, oranges, low-fat milk, bananas, salmon, and dried beans. So these are foods that are high in potassium to help you increase his dietary intake. Again, we can even give potassium supplements IV up to 40 milliequivalents per liter is the usual concentration. You cannot give greater than this level or this concentration into the peripheral IV without a cardiac monitor. So you don't want to give higher than these levels. And again, you don't want to give potassium without a cardiac monitor connected to your client. Again, there's also an increased risk of digoxin toxicity. So you want to monitor this client, also assess renal function prior to administration. With hyperkalemia, now we want to restrict dietary potassium and potassium-containing medications. We can give our kayakzylate to help us excrete this excess potassium. So if you're giving orally, you want to dilute to make it more palatable so that the client can comply. If you're giving rectally, you want to give in conjunction with sorbitol to avoid fecal impaction. Also, in emergency situations, calcium gluconate given IV, or even your sodium bicarbonate, or our regular insulin and dextrose. This would all help to shift potassium out of the cell, into the cells. So you want to give this in emergency situation. We might need to carry out peritoneal or hemodialysis, and we might need to start the client on diuretics. The last but not the least would be our sodium imbalance. Sodium is also another important extracellular ion that's responsible for water balance. So a normal level should be between 135 to 145 milliequivalents per liter. In hyponatremia, we see levels that are less than 135 milliequivalent per liter, and our sodium could be depleted in the body as a result of vomiting, excessive vomiting, diuretics, excessive administration of dextrose and water IVs, prolonged low sodium diet, or excessive water intake. So you will see nausea in this client, you will see muscle cramps, there will be increased intracranial pressure, the client will be confused, there could be convulsions and muscle twitching. So our plan for this client would be oral administration of sodium-rich foods like our carrots, radish, your bell pepper, cucumber, broccoli and cabbage, even tomatoes. So we can also give beef brutes. Again, we could give IV lactated ringers or 0.9% sodium chloride. So you can see the sodium there. So that will help to build up the sodium level. And again, we want to carry out water restriction, which is a safer method. So also keep your intake and output charts and daily weight records. In terms of hyponatremia, we see levels above 145 milliequivalent per liter, usually caused by the high sodium levels are caused by hypertonic tube feedings without water supplement. So you have tube feedings that are hypertonic and the client doesn't get water supplements. So this could cause it. Diarrhea is also another cause. Hyperventilation, diabetes insipidus, ingestion of over-the-counter drugs such as your Alka-Seltzer, or inhaling large amounts of salt water, for example, near drowning. Also inadequate water ingestion. So all of this could cause hypernatremia. So what do you see in your clients? There's going to be weakness, disorientation, delusions, and hallucinations. There's thirst, dry, swollen tongue, sticky mucous membranes. There's also postural hypotension with decreased ECF, or you could see hypertension with normal or increased extracellular fluid. And then we'll also see tachycardia in these clients. In terms of our plan, we could give IV administration of hypotonic solution, like your 0.3% sodium chloride or 0.45% sodium chloride. We could also give 5% dextrose in water. Again, you want to offer fluids at regular intervals. You also want to decrease sodium in the diet and also monitor the client's daily weight.